So prior to luspatercept, there were no FDA-approved agents. We used erythropoietin-stimulating agents, knowing that the mechanism of myelodysplastic syndrome is where you have a hypercellular bone marrow, and we're just going to essentially stimulate the bone marrow more effectively. The COMMAND study is the first head-to-head study that's been available that showed directly compared luspatercept against erythropoietin agents. And in that study, we found that it doubled the response rate. Response rate went from 30% with EPO agents to 60% response rate with luspatercept. The duration of response was a full year longer. So with luspatercept, it went from 1.5 years with EPO agents to 2.5 years with luspatercept. In terms of the overall, so we have longer duration of effect, we have better, and also the hemoglobin rose by an average of 2 points as opposed to only 1.5 points with EPO agents. And so we have a longer duration of effect, we have higher proportion of patients responding, and we have a higher rise in hemoglobin. There's some recent data that was just published today in a poster presentation at SOHO, where in 2024, that showed that when you raise the hemoglobin more effectively with luspatercept, it also reduces hospitalizations and it reduces the number of clinic visits that the patient has to have. Patients feel a lot better when their hemoglobin has been raised and has raised more effectively. So the administration for luspatercept is a little bit different than administration for EPO agents. So EPO agents traditionally weren't started until the hemoglobin is less than 10 and were held once the hemoglobin was over 11. The package insert says to start luspatercept when the hemoglobin, or you can start for patients who are potentially needing a blood transfusion and whose hemoglobin has dropped below 11, and to hold it once the EPO levels go above 11.5. And then restart it when an EPO goes back below 11. So it's a little different according to the package insert. Well, there's some significant benefits to luspatercept. I mean, you're raising hemoglobin more for longer periods of time, patients feel better with that. But it also appears to be working on the white blood cells as well as the platelets. So you're having other cell lines also being affected as well. Those are great. And in terms of it, when your hemoglobin stays longer for a higher period of time, stays higher for a longer period of time, potentially those patients are not going to fail therapy and, aren't going to need hypomethylating agents for a much longer period of time, hopefully never. For the ring sideroblast negative, it appeared as if the efficacy was relatively similar in the COMMAND study compared to EPO agents. But it looks like when they dug a little bit deeper that they weren't really randomized to apples there. It looks like the cell lines who were on the luspatercept, or the patients who were treated with luspatercept, who were ring sideroblast negative, had significantly more genetic mutations than the patients who were on the EPO arm. So maybe not exactly the same, but frankly, from my perspective, the patients are needing one shot every 3 weeks instead of weekly. Their hemoglobin is raising higher and it stays higher longer. So there's lots of benefit, even if they were exactly the same, which it doesn't appear as if they were. It is a little less expensive, and so if you've got patients that don't necessarily mind coming every single week, but it's not raising the hemoglobin as much, it's not raising it as long, so I see it as an inferior product that's wasting a lot of time and energy for the patient as well as their loved one. 52 visits a year as opposed to only 17 visits a year on average. So, I mean, luspatercept is certainly my frontline agent. I mean, it's just much more convenient and much more favorable. I mean, it depends on your individual practice's cost.